Hello and welcome to Chapter 8 in Alternate Care Systems. In Chapter 8, we're going to be discussing substance abuse. This kind of follows along with our behavioral health and mental health chapter that we just finished. All right, so starting over on page 270 in the textbook, you have different settings and their description and synonyms and examples of each type of the facilities we're going to cover. So starting an intro to setting, we're going to slide past all these learning objectives. Substance abuse is a major health problem in the United States. Many different types of treatment settings are available to substance abuse clients seeking assistance, including public and private facilities that provide a full range of services, from educational programs to medically managed intensive patient care. In 2012, 23.1 million people aged 12 or older required substance abuse treatment. Of those, 2.5 million received treatment in a specialized facility for substance abuse issues. And so we're going to talk about the care setting and some of the different areas that you may receive treatment if you have substance abuse problems. So starting at the bottom of 271, the following are some of the more common settings for substance abuse treatment and services. However, this is not an exhaustive list. For simplicity, the programs discussed in this chapter have been grouped by care setting under the following general headings. So number 1, we have outpatient treatment. Number 2, intensive outpatient or partial hospitalization treatment. Number 3, we have residential inpatient treatment. Number 4, aftercare or continuing care. 5, educational and prevention programs. And number 6, self-help recovery groups. And so if you go back to 271, you see in that top section that it talks about Alcoholics Anonymous. And so we're going to talk about that a little more when we get to our self-help and recovery groups. So within the substance abuse treatment community, similar programs sometimes are found in an inpatient, outpatient, or community setting. For example, the Alcoholics Anonymous 12-step philosophy and program originated as part of a self-help recovery network, but over the years, this philosophy also has been incorporated into programs at both inpatient and outpatient treatment facilities. As a general rule, clients should be treated at the lowest or least intensive level of care that will accomplish their treatment goals. The levels are discussed in this chapter as discrete entities, but in reality they represent the continuum of substance abuse treatment services available to clients in most of the country. So let's start with our outpatient treatment center. Outpatient treatment consists of regularly scheduled sessions with a mental health professional. These sessions can include individual therapy, group therapy, or family therapy. Outpatient providers such as mental health centers, hospital-based outpatient centers, and freestanding drug and alcohol treatment centers currently treat substance abuse clients through a variety of treatment modalities, including individual, group, and family therapy. Individual therapy currently is the most common form of outpatient treatment, accounting for 76% of all treatment sessions. Outpatient therapy typically is a long-term commitment for a client, lasting up to a year or more. Some examples of specialized outpatient treatment programs are methadone maintenance programs for heroin addicts, organized school intervention programs for adolescents, court-related programs for individuals convicted of substance abuse-related offenses, and employee assistant programs that contract with companies within the community to provide care to their employees. Then we have our intensive outpatient or partial hospitalization treatment. So intensive outpatient or partial hospitalization is more structured, rigid form of treatment that is regular outpatient treatment. Intensive outpatient treatment requires a minimum of 9 hours of weekly attendance, usually in increments of 3 to 8 hours a day for 5 to 7 days a week. This treatment often is recommended for patients in the early stages of treatment and for those transitioning from residential or hospital settings. This environment is suitable for patients who do not require full-time supervision and have some available supports but do need more structure than is typical of less intensive outpatient programs. This treatment option encompasses day treatment or group programs that may offer a full range of services, including outpatient detoxification at times. Intensive outpatient treatment programs allow adult clients to continue working and adolescent clients to continue schooling while providing a structured treatment environment. Partial hospitalization programs typically are day treatment programs that provide more treatment hours for clients with more severe levels of illness. Clients can spend all day in the treatment program but return home each evening. Then we have our residential and inpatient treatment. So our residential and inpatient treatment is directed at clients with subacute medical, behavioral, or emotional problems. Residential treatment provides a live-in facility with 24-hour supervision. This type of treatment is better than the outpatient treatment for consumers with an overwhelming substance abuse problem who typically are without the motivation or social supports to abstain from using. The length of stay in these facilities ranges from short-term to long-term. Some programs offer less restrictive types of treatment, such as halfway and quarter-way houses, to help the consumers transition back into the community. And then we have our educational prevention programs and early intervention. Society places significant emphasis on awareness and prevention of substance abuse problems. Substance abuse facilities, particularly those in the public sector, frequently are involved in providing structured prevention, education, and awareness programs. The clients served by these programs differ from those who receive substance abuse treatment. These clients do not necessarily have substance abuse or dependence diagnoses, but are considered to be at risk for problems in the future. Many participants in educational programs are children or adolescents who have been identified by the schools, social service agencies, or legal system as having the potential to develop substance abuse problems or who have family members with existing substance abuse problems. SAMHSA, SAMHSA's Center for Substance Abuse Prevention administers a number of grant programs aimed at reducing the incidence of substance abuse. Recognizing the cost-effectiveness of prevention programs, CSAP provides national leadership for community-based prevention programs. And last, we have our self-help recovery groups. Arguably, including self-help recovery groups in a list of substance abuse care settings is not appropriate because they are designed to be voluntary and to provide support rather than treatment for recovering addicts. These groups, however, provide lifelong assistance to many individuals with substance abuse problems and are considered to be a significant factor in many successful recoveries. The most widely recognized self-help organization is Alcoholics Anonymous, a program in which members follow a 12-step program that leads to recovery. AA was founded in 1935 and had reached national prominence by the 1950s. Since that time, AA has spawned other self-help groups such as Narcotics Anonymous that adhere to a similar 12-step philosophy. No records are kept by the 12-step support groups because anonymity is a key element in the recovery programs. Nevertheless, 12-step programs have reached such prominence in the substance abuse treatment community that many providers actually integrate the philosophy into their treatment services, and this is reflected in client records. Even though AA is the most widely accepted network of substance abuse self-help groups, other approaches are available as well. For example, some programs offer support groups based on various adaptations of cognitive behavioral therapy as a means of recovery. Client participation in a support group, regardless of the group's philosophy, improves the chances that the client will stay sober. All right, so let's talk about the types of clients seen in substance abuse treatment. With the various types of substance abuse settings and programs, the clients served range in age from infants to the elderly and come from all socioeconomic backgrounds. In addition to identifying broad categories of clients, such as inpatients and outpatients, facilities often further identify segments of their clients' population based by factors such as age, sex, type of referral, or legal status. This categorization facilitates program planning and administration. In many cases, educational and treatment programs can be tailored to meet the needs of specific client groups. Some examples of client groups served by specific programs or protocols because of their special needs are adolescents, women, clients referred to employee assistance programs, clients who have been dually diagnosed with a mental disorder and a substance abuse disorder, and clients who have been court referred. A recent trend is to provide group sessions to individuals who are incarcerated. These sessions are provided to the individuals while they're in jail or other correctional settings. All right, so let's talk about adolescents. So, in addition to potentially causing problems with family, friends, and schoolwork, use of alcohol and other drugs by adolescents can lead to dangerous patterns of lifelong abuse. And so there was a survey done in 2011. It was the National Youth Risk Behavior Survey. It showed that about 71% of high school students have tried alcohol. And this is actually a reduction from 75% in 2007. Healthcare providers, teachers, and parents now recognize that an adolescent can develop serious abuse and addiction problems as a result of this early experimentation. In 2011, the National Survey on Drug Use and Health reported that an estimated 12.9 million adolescents between the ages of 12 and 17 used alcohol, and 8.5% reported binge drinking. This does not include the number that sought treatment for drug issues. All right, so let's talk about women next. Awareness is growing within the substance abuse treatment community that women, particularly pregnant women and women who are parents of young children, have special care and support needs, as do their children. In 2011 and 2012, 8.5% of women were pregnant when they were admitted to alcohol abuse treatment. Treatment of pregnant women should be a priority because the welfare of both the mother and the unborn baby are at stake. Fetal alcohol syndrome and cocaine addiction in newborns can lead to serious health and developmental problems for children. Programs developed for pregnant women might include child care incorporating therapeutic activities to assist the children in learning to deal with issues related to living with an addicted parent, and easy access to intensive prenatal care and case management services. All right, moving on to our EAP clients. Many substance abuse agencies and treatment facilities have established employee assistance programs, or EAPs, to serve working adults and their employers. Businesses contract with local substance abuse organizations to provide services to their employees. Employers have come to recognize that substance abuse problems will have a negative impact on job performance, and that it is in their best interest and that of their employees to encourage treatment of these problems. Employees can be referred to the EAP by their employers, or in some cases, the employees will seek out the EAP services themselves. As in other substance abuse treatment programs, strict confidentiality of EAP client information is maintained, regardless of the referral source. And then we have our dually diagnosed clients. And we talked about these dually diagnosed clients in the last chapter when we discussed mental health. So a growing portion of the substance abuse client population is dually diagnosed with both a substance abuse or dependency disorder and a chronic mental illness. These clients typically have difficulty succeeding in traditional alcohol and drug treatment programs and self-help groups, which has led to the development of programs designed to meet their special care needs. By using assessment tools specifically designed to identify dually diagnosed individuals, treatment facilities can better plan the course of treatment for clients. And last, our court-referred clients. Individuals who are arrested and convicted of alcohol and other drug-related offenses frequently are referred to substance abuse treatment programs for drug and alcohol awareness education, a substance abuse assessment, or substance abuse treatment. When an individual is convicted of driving while intoxicated or driving under the influence of alcohol or drugs, the court may order, for example, that the individual has to enroll in an awareness program and to obtain a substance abuse assessment to determine whether treatment will be required. DUI clients are not the only court order related clients seen by substance abuse facilities. Persons arrested or convicted of other alcohol or drug-related offenses may also be referred to obtain assessment and treatment. All right, so let's talk about the types of caregivers in substance abuse care. Of course, we have our physicians. Some physicians specialized in the treatment of chemically dependent patients, Also, psychiatrists, family practitioners, or other physicians with the general practice orientation can be involved in substance abuse treatment. Any treatment plan that requires a medical intervention, such as a prescription medicines or detoxification services, is monitored, if not managed, by a physician. Then we have our physician assistants and PAs. Just like in other segments of healthcare, the role of advanced practice clinicians or mid-level providers, our physician assistants and nurse practitioners, varies from state to state and from facility to facility. As a general rule, these professionals treat clients under the supervision of a physician. However, some states allow more independent practice. And then we have our nurses. So in addition to medical care and substance abuse treatment, clients in inpatient substance abuse facilities require nursing care. The extent of nursing service in a facility depends on the level of care it offers. An acute care hospital setting provides 24-hour nursing care to its substance abuse patients, just as it does to other patients. Then we have counselors. Counselors are professionals such as social workers and psychologists with special training and experience in treating clients with substance abuse problems and mental health issues. The educational background of these individuals varies and may depend in part on the state's facility licensure, practitioner license, and Medicaid regulations. The counselor provides individual, group, and/or family therapy to the client and the client's family according to the treatment plan. Frequently, the counselor is recognized as the client's primary therapist, particularly in an outpatient setting. The primary therapist is the caregiver responsible for coordinating the client's treatment, including an assurance that all documentation requirements are met. And then we have case managers. As with substance abuse counselors, substance abuse case managers come from a variety of professional and educational backgrounds. They may be nurses, social workers, or educational specialists. The case manager's role in substance abuse treatment depends on the level of care and the specific care setting. In an inpatient setting, the case manager may focus primarily on reimbursement issues and organizing follow-up care. The case manager in an outpatient setting assists the client with these and other non-treatment activities such as obtaining adequate housing, securing financial assistance, keeping medical and counseling appointments, and so on. And then we have our recreational therapist. Long-term inpatient and other residential treatment programs often employ recreational therapists to work with clients. Recreational therapists design therapeutic recreational activities for residents while they're undergoing treatment. For example, a residential treatment program for adolescents might incorporate a challenge course or other outdoor activities designed to build trust and self-esteem. Adult clients may utilize exercise equipment or engage in basketball games. All right, so let's move on to our regulatory issues section. Several public and private agencies regulate or set standards for substance abuse treatment facilities and programs. One set of federal regulations, Confidentiality of Drug and Alcohol Abuse Records, 42 CFR Part 2, mandates that any federally assisted substance abuse treatment program must adhere to strict confidentiality guidelines and legal procedures. Substance abuse treatment records historically have been the only category of health record related, except those created in government-operated healthcare facilities such as VA Affairs or Veterans Affairs and Indian Health Services hospitals, whose security and confidentiality are specifically protected by a comprehensive federal law. HIPAA also provides guidelines for confidentiality of protected health information. The federal law that protects substance abuse programs and their information is more comprehensive than HIPAA requirements in some ways. Therefore, a substance abuse program has not fundamentally changed their approach to maintaining confidentiality. Two major private, not-for-profit, voluntary accrediting agencies that set standards for substance abuse facilities are the Joint Commission and CARF International. The government standards that are applied most frequently to substance abuse treatment programs are state Medicaid guidelines. Facilities treating Medicare clients also have to comply with the applicable conditions of participation. So be sure to read down through there about Joint Commission, and then you've got more information on CARF as well. And then they talk a little bit more about Medicaid programs on page 282. All right, let's move on to documentation. This is going to be the last section we cover in this lecture, and we'll pick up with the rest of the chapter in lecture 2. So as in other healthcare settings, substance abuse facilities require clear and consistent documentation. Good quality documentation of care, whether done manually or electronically, is essential. The primary purpose for maintaining client records is to support client treatment. Other purposes for the records include to improve communication among care providers, to serve as a legal records of care provided, to support reimbursement claims, to monitor the quality of care, and to provide data for research and education. Records are increasingly important for documenting evidence-based practices and outcome measures. Facilities have to demonstrate that a client's treatment was successful. Documentation can help to support this by indicating an increase in the patient's level of functioning or by documenting recidivism rates. The following list, adapted from South Carolina Department of Alcohol and Other Drug Abuse Services Uniform Clinical Records, represent typical information that might be found within the record of substance abuse client and is divided into two general groups. You have your legal, administrative documentation, and you have your client clinical documentation. The legal administrative portion of the client record typically includes essential non-clinical information such as demographics and identifying information, along with any required legal documentation. Examples include admission information, commitment papers, fee agreement and financial assessment, insurance authorization, special program enrollment forms, program or agency rules, consents to treatment, consents to release of information, client rights information, and notice of privacy practices. The clinical portion of the client's record documents the direct care provided and might include such items as clinical assessments, medical assessment if necessary, individualized treatment plan, clinical service notes or progress notes, and there may be daily or weekly summary notes depending on the type of program and the applicable standards. The discharge summary and the aftercare plan, follow-up information, and a list of medications and allergies. Two key documents in the substance abuse record are the clinical assessment and the individualized treatment plan. Each client should receive a thorough clinical assessment before the development of his or her individualized treatment plan. This assessment typically includes documentation of identifying information, presenting problem, health, medical, and other or developmental history, family and social history, history of psychoactive substance abuse or substance use, history of psychological factors impacting the patient or the client's condition, educational, vocational history, client abilities, strengths, needs, and preferences, preliminary diagnoses, admission to program information including specific reasons when admission is denied, initial problem list, and the clinical assessment summary. Because the severity and unique treatment considerations of substance abuse programs vary slightly from one client to another, an individualized plan of treatment must be established for every case, even if the client's diagnoses are the same. For example, one client with a diagnosis of cocaine abuse might require both an inpatient stay and outpatient therapy, whereas another client might only need outpatient therapy. The individualized treatment plan is the document in the client's record that is intended to guide the clinician and the client through the treatment process. Therefore, the ITP must be based on the client's comprehensive clinical assessment. An ITP typically includes identifying information, DSM-5 diagnoses, strengths of the individual, justification or reason for treatment, including duration and frequency of the problem, proposed treatment process, including the type of service and frequency, treatment goals and objectives that are measurable with target achievement dates. The ITP is updated periodically to reflect changes in the client's condition and revised treatment goals. The ITP should be a flexible document designed to meet the treatment needs of the individual client. Both CARF and the Joint Commission have developed standards for the ITP. And so if you go back to page 285 in the text, figure 8.3, they have sample clinical assessment forms. And so you see they have each one of these little sections labeled. So you have a presenting problem, the patient's medical history, You have a section for their family and social interaction, and then you have a chart with different drugs listed on it, so that you can figure out when their age at first use was, their frequency of using, quantity, the last use, and how they used it. Any psychoactive substance use listed, psychological, educational, vocational, and so you've got this long assessment. And there's two actually. So a second example assessment starts on page 289. So take a look through those, and we will pick up with reimbursement and funding in our next lecture. Happy reading.